I'm going to talk about HER2 positive metastatic breast cancer. My first abstract is pertuzumab plus high dose trastuzumab in patient with progressive brain mets in HER2 positive MBC. It is a primary analysis of phase 2 study. So effective therapies are there for HER2 positive MBC, but still 40 to 50% of the patient do develop brain metastasis. A trastuzumab radioisotope has been shown to localize in brain mets of patients with HER2 positive MBC, and intracranial xenograft models have demonstrated a dose-dependent response to trastuzumab. So this was phase 2 Patricia study, was a single arm open label study that examined pertuzumab plus high dose trastuzumab 6 mg per kg weekly in patients with HER2 positive MBC with CNS metastasis that had progressed following radiotherapy. The primary endpoint was confirmed overall response rate in the CNS as per the RANO-BM criteria. Secondary endpoints were duration of response, clinical benefit rate at 4 and 6 months in the CNS, and safety profile. So inclusion criteria was confirmed HER2 positive MBC presented with documented CNS progression despite prior radiotherapy and stable extracranial disease. Exclusion was for abdominal disease, symptomatic pulmonary disease, history of intolerance or hypersensitivity to study treatment, significant cardiac disease or active infection. So you can see what is interesting in this table is if you see the bottom part, that is prior HER2 targeted treatment, 50% of the patient had received trastuzumab and pertuzumab. Around 40% had received both TDM1 and 40% had received lapatinib, and around 10% of the patient did receive neratinib in this study. Coming to the result, efficacy within the CNS as per the RANO-BM criteria, the overall response rate, which was the primary endpoint. As you can see, it was a small study of 37 patients. The overall response rate was 11%, and clinical benefit rate at 4 months was 68%, and clinical benefit rate at 6 months was 51%. In this heavily pretreated population. This is the swimmer plots narrating the same data. Coming to the side effects, cardiotoxicity was a major concern because giving trastuzumab 6 mg per kg weekly was a major concern. And despite that, only one patient out of this 39 developed this cardiac toxicity. Other common side effects were diarrhea and fatigue. Overall, it was manageable, and it was that clinical benefit was observed in patients with prior exposure to TDM1, lapatinib, and or neratinib. Notably, extracranial disease response were stable or better in patients with clinical benefit in the CNS. So the author's conclusion was that although the CNS response rate observed in Patricia was modest, 11%, the majority, that is 70% of the patients, experienced clinical benefit, and 2 patients had ongoing stable intra and extracranial disease control for 2 years. Importantly, no new safety signals were observed despite this high dose of trastuzumab along with pertuzumab. So this data suggests that pertuzumab plus high dose trastuzumab may be of clinical utility in some patients with HER2 positive MBC and progressive CNS metastasis. There is a potential to further optimize the dose and schedule of monoclonal antibodies. Further studies may be warranted to clarify whether additional CNS gains could be made by combining high dose trastuzumab with chemotherapy and or other targeted agents. My SWOT analysis says that strength about this study is proof of concept. I look at it as a proof of concept study. Clinical benefit rate of 50% at 6 months in this heavily pretreated population who had received TDM1, lapatinib, neratinib is wonderful. Cardiotoxicity is not a major concern as per the data. Also, we can say limited data we have. Coming to the weakness, it was a single arm study. We already have a very strong data of around 300 patients wherein tucatinib, trastuzumab, and capecitabine are given, and they have a tremendous overall response rate ranging from somewhere around 60 to 70%. Also, TDX, that is trastuzumab deruxtecan data, we have for around 150 patients where response rate is close to 40-50%. So compared to this, the response rate with the available regime is quite less. Opportunity, we can consider it using beyond tucatinib and trastuzumab. Suppose tomorrow these 2 molecules are available in our country. Threat, this can create a threat because we may be inclined to use this regime rather than going for tuca or TDX. So using it before tucatinib or TDX can be a threat, and we should, not do this. Take home message, I would consider this option after progression on tucatinib and TDX. Provided these 2 molecules are available in our country or they are available by a compassionate access program. My second abstract is about the SYS-UCC002 randomized controlled trial. Trastuzumab plus endocrine therapy or chemotherapy as first line treatment for HER2 positive and hormone positive metastatic breast cancer. So this has been an unanswered question, that what to give first in a triple positive metastatic breast cancer patients. We are all inclined in giving chemotherapy along with HER2 positive disease in all patients, but this study answers whether can you avoid chemotherapy in those patients who are also hormone positive, and whether hormone plus trastuzumab gives the same result as chemo plus trastuzumab. So this was the trial design. Triple positive MBC patient were included, and if they are prior treatment, the disease-free interval should be at least 12 months. The randomization was 1:1 to hormonal agents, either estrogen or AIs, estrogen receptor modulators or AI plus trastuzumab, or chemotherapy group, which can be taxane, capecitabine, or vinorelbine. Primary endpoint was PFS, secondary were OS, overall response rate, and safety. This is the PFS Kaplan-Meier curve. As you can see, both the curves are going neck to neck, and with a hazard ratio of 0.88. So more or less they were showing the same benefit. But if you see the numbers down there, in the chemotherapy group at say 60 months, there were 9 patients, and endocrine there will be 11 patients. So almost it was similar in both the arms. Coming to overall survival, you can see the red one is the endocrine therapy curve. It is slightly crossing over after a few months, say around 12 months, and they can see some separation after 12 months, and the separation is maintained even till 84 months. Although hazard ratio was 0.82, p-value was 0.009. It was not significant statistically. Coming to the numbers, this is something interesting for the OS data. The chemotherapy group at 60 months, say 5 years, there were 16 patients, while endocrine therapy there were 33 patients. So there was double the number of patients alive with endocrine therapy at 5 years. As we all know, endocrine therapy, those who are endocrine hormone receptor positive, they tend to have later relapses. But those receiving this, more patients were surviving at 60 months compared to the chemotherapy arm. Although there was no difference in the hazard ratio. Coming to the forest plot, all the subgroups were benefiting. But what was remarkable was the disease-free interval. Those patients with a disease-free interval of less than 24 months, chemotherapy arm was showing better results, while those with DFI of more than 24 months, endocrine therapy was showing better results with a significant hazard ratio of 0.77. Toxicity, diarrhea, nausea, vomiting, alopecia, leukopenia were significantly reduced in the hormonal therapy arm, as we all know, because chemo was not there in that arm. Conclusion, author's conclusion is that trastuzumab plus endocrine therapy was non-inferior to and had fewer toxicities compared with trastuzumab plus chemotherapy in patients with triple positive MBC. Exploratory analysis revealed that trastuzumab plus endocrine therapy was likely more beneficial in those who have DFI of more than 24 months. Similarly, chemotherapy plus trastuzumab was more beneficial in patients with DFI of less than or equal to 24 months. My SWOT analysis strength of this trial is a phase 3 randomized controlled trial with 1:1 randomization. It addresses an unanswered question which nobody has compared in a randomized fashion. So it becomes a strong basis for avoiding chemotherapy in somebody who is a borderline fit. Weakness, suboptimal treatment in both the arms, that is pertuzumab was not given. It was a non-inferiority trial. So always there is some technical, there is a lot of statistical issues involved in non-inferiority trials, with which we need to look and see deeper into. Opportunity, this helps to identify who among those less than 24 months need chemotherapy. That is, should we restrict to those with having a DFI of less than 12 months, or should we include all, that is less than 12 as well as 12 to 24 months DFI as well? So we can identify out of this two, can we identify that's an opportunity for us. Also, that's good data coming on CDK4/6 inhibitor plus either an AI or fulvestrant along with dual anti-HER2 inhibitor. I've read some data of this, a combination in neoadjuvant therapy where overall response rate was 100%. There was a small study of few patients, but that is quite interesting. And that was again, I think, a proof of concept study. And we need to see whether we can utilize this combination for this triple positive metastatic breast cancer patients. Threat is over or underutilization of chemotherapy based on this trial. So this is my SWOT analysis, and my take-home message is I would consider endocrine therapy over chemotherapy in all patients who are unfit for chemotherapy. Especially, even I may consider for somebody who is borderline fit. Late relapses, that is less than 24 months, definitely I'll be happy to go with endocrine therapy. For chemotherapy, I would consider those patients who had early relapse, especially less than 24 months. I would definitely be more inclined to go for chemotherapy plus trastu combination. And would add HER2 as well based on the Cleopatra study. I am interested to know the data of the CDK4/6 plus AI or fulvestrant and dual anti-HER2 inhibitor. This will be really interesting to see. Thank you.